Coming to you live from our production studio in Washington, D.C. Good morning. Welcome to the third annual Cardiovascular Health Policy Summit. I'm Ryan Googe, Executive Director of the Partnership to Advance Cardiovascular Health. First, I want to thank our co-hosts, the Alliance for Patient Access and the Institute for Patient Access, for helping us develop today's program. I also want to thank our generous sponsors who have made today's program possible: Amarin, Amgen, Bristol-Myers Squibb Pfizer Alliance, Esperion, and Janssen. We have an exciting program today, and I'm very grateful to be joined today by my colleagues Jasmine Patel and Lindsay Vidinix. We'll be hosting today's program.
Hi, I'm Lindsay Vidinix. I am the Working Group Manager for the Cardiovascular Disease Working Group at the Alliance for Patient Access.
And I'm Jasmine Patel, the Director of Policy and Outreach for the Partnership to Advance Cardiovascular Health.
Well, we have an exciting agenda ahead. Our speakers today are cardiovascular clinicians, advocacy leaders, policy experts, and patients who are joining us virtually from all across the United States. And under normal circumstances, we would be hosting this conference in Washington, D.C. You'll notice on the live stream page you're currently viewing, there are two boxes, one for question and answer and the other for chat. We encourage you to engage with each other in the chat box. And in the Q&A box, you can ask our panelists questions. Please don't feel like you need to wait until the end of the panel to submit your question. You can submit them throughout the panel, and we'll do our best to answer them at the end of each segment. And if you're on social media, please join the conversation around this summit by using the hashtag #CVSummit2020.
As you scroll through the live stream page, you'll also find bios for all of today's speakers, the agenda, and videos and resources from Patch. We encourage you to download and share those resources. You can also find more resources and information about Patch at advancedcardiohealth.org. Now it's my pleasure to introduce our first speaker, who will deliver opening remarks. Dr. Dharmesh Patel is the President of the Board for the Partnership to Advance Cardiovascular Health. He's passionate about cardiovascular disease prevention, works tirelessly for his patients, and today is joining us from Memphis, Tennessee. Welcome, Dr. Patel.
Well, thank you so much, everybody. Thank you, Ryan, Lindsay, and Jasmine, and good morning to everybody. Very excited. My name is Dharmesh Patel. I'm a cardiologist practicing in predominantly Memphis, Tennessee. I am pleased to welcome you to the Cardiovascular Healthcare Policy Summit. Thank you so much for joining. Whether this is your first time with us or your fourth, I think you'll agree when I say this. This year, 2020 has presented enormous challenges for cardiovascular health. In many cases, medical care for conditions like heart disease, diabetes, or high cholesterol has lapsed, either because patients are afraid of contracting the coronavirus or because life during the pandemic has forced them to lay their own healthcare concerns aside. Think about it. Many people, maybe even you, found themselves suddenly and unexpectedly the primary caretaker for a sick loved one, a teacher for their young children now attending school online, a first-time telecommuter adjusting to doing their job solely within the walls of their own home, or a furloughed employee questioning when normalcy, work, and financial security will return. It's easy to see how something like high cholesterol or blood glucose could be pushed to the back burner. Healthcare providers have struggled too. We committed ourselves and our staff to the highest level of caution and cleanliness for our clinics and hospitals. We revisited office procedures to respect social distancing. We implemented telemedicine, some for the very first time, and worked with our staff and patients to understand how to use it effectively and efficiently. But most of all, we all search for the best way to send our patients this one critical message. Even now, when the world feels like it's unraveling, your cardiovascular health is imperative. To patients this morning, I urge you, don't get lost in the minutiae. This isn't about levels and dosages or LDL or DLs. It's about cardiovascular health. It's quite literally about your life. The quality of your life, the quantity of your life. The way you spend your days and weeks now and the way you spend your years that you have ahead of you. Now, this morning, we find ourselves at a policy summit. Why policy? Because next to the commitment that patients and providers make to cardiovascular health, policy decisions have perhaps the biggest impact on the ability to receive optimal care. Good policy can make optimal cardiovascular care easier. Poorly conceived policy, on the other hand, can make optimal cardiovascular care much, much harder. Because we care about cardiovascular health, we care about policy. But even more than that, we stand by the power of patients and healthcare providers, everyday people, to change policy. And we need good policies, do we ever? Even before COVID-19, our nation's cardiovascular healthcare was hurting. Consider some of these sobering facts. Someone in the United States dies from cardiovascular disease every 36 seconds. Every year, more than 800,000 Americans have a heart attack, and about 1.5 million are newly diagnosed with diabetes. 93 million Americans have high cholesterol, but interestingly, only half are taking medications to control it. And within the last few years, after decades of improvement in cardiovascular health, we saw progress begin to fade. Deaths from heart disease stopped declining and actually, soberingly, have started to increase. I even heard recently, this may be the first time that the later generation outlives the younger generation. But we're here this morning because we know that good policies can help change the situation. Policies that raise awareness, encourage access, and elevate that crucial bond of trust between the patients and their healthcare providers. With the help of people like those gathered today on this call, we can, step by step, improve cardiovascular health and cardiovascular healthcare in this country. So at today's summit, I'm excited that we'll be talking about weathering the ongoing pandemic, how patients, providers, and policymakers can prioritize health, heart health, and as we continue to fight the coronavirus. What patient-centered care looks like in practice for cardiovascular patients. How a presidential election could shape healthcare policies and impact and access for our patients. And finally, how the ongoing debate about cost and value in healthcare impacts a cardiovascular patient population that definitely isn't a one-size-fits-all. I look forward to hearing these discussions alongside you, and I encourage you to use the interactive features on your screen too. Share comments, ask questions, or review the resources provided. Lastly, I urge you to see the light at the end of the pandemic tunnel. Tough times so often bring powerful and meaningful change. Let that be the case with cardiovascular healthcare policy. Let's not only engage in this conversation today, but join together in the days ahead to advocate for policies that protect the hearts, the health, and the lives of so many people. Thank you. At Patch, it's very, very important for us to include the patient voice in our advocacy work. To start, our first panel on cardiovascular care, COVID-19, I'm very excited that we're going to hear an interview between Ryan and Reverend John Wilkins and his daughter, Joyce Jones. Reverend Wilkins is a COVID survivor from Mississippi who is also well known to me, a local musician who travels around the world and a blues legend. He battled COVID for 5 weeks and is now dealing with long-term health complications as a result. Ryan recorded this interview a few weeks ago, and we can play that now. Thank you very much.
Whether in Memphis or another country, Reverend John Wilkins and his daughters are most at home on stage. They were even supposed to go to Germany last month, but the coronavirus got in the way, and not just because of the travel ban.
My dad had called me on the day of April 4th and told me he wasn't feeling well. And I noticed in his voice, it sounded like he wasn't breathing really well.
When Joyce Jones got to her father, he had a fever. She rushed him to Baptist DeSoto, where he was admitted and diagnosed with the coronavirus. Jones says soon after, they put her dad on a ventilator in the ICU.
A couple of times they told us that we almost lost your dad.
They said I was out of it for 15 days.
Wilkins doesn't remember much from his 5-week hospital stay, but you can see his daughters were checking in a lot on him on video chat with the help of his nurses. Slowly, he started to turn around. His family credits the staff and prayer with his miraculous recovery.
I have more faith than fear. And so, that's what brought us through this point. The day when they rolled him out of that hospital, saying that he was COVID-free, that he could be discharged to come home, there was a shouting spirit.
Now they're welcoming him home with signs and T-shirts that say he survived it. Wilkins is touched. He tears up as he talks about this journey.
I gave God some praise, because he's been good to me.
In that spirit, he says he will perform again. In Southwest Memphis, Stacey Jacobson, WREG, News Channel 3.
Hi, Reverend Wilkins. Hi, Joyce. How are you?
Hello, great, thank you.
Thanks so much for joining me. I really appreciate it. To get started, I wanted to ask Reverend Wilkins, I want to talk about your life before, this 5-month saga that or 5-week saga that you've been through. So can you tell me a little bit about, your life, where you're born and raised, a musician, so on and so forth. So can you just give our audience a little bit of background about you personally?
Okay. I started playing music at a 5-year-old. After that, I got about 10, and I started playing for gospel groups in the city. And after I got on up to in a teenager, I was doing both of them. And I had to quit doing both of them and just do one. Yeah. I got off into the ministry and started pastoring church and all that. So that's where I'm at now.
That's great. So Joyce and Reverend Wilkins, can you tell me a little bit about when you realized that something was wrong?
Yes, that was on April 4th. My dad called me and said he wasn't feeling really well. His back was hurting him, that he had fallen off the back of his truck a couple of days before that. So I drove over there, and when I got there, I noticed he was very weak, and his voice was very weak, and his breathing wasn't really good. So I felt his forehead. It felt hot. At that point, I knew he was going to have to go to the hospital, which he did not want to do. So I called my other two sisters over the phone, and we decided he had to go to the hospital right away.
Did you think at any point that there was something really wrong?
No, I didn't. No.
I think we all were thinking, since he told us he had fallen off the back of a truck, and he didn't let us know that he was having this back pain from falling off the back of the truck. Not thinking anything about COVID. We were more thinking it was from an accident of falling off the back of the truck.
So you went to the hospital. Did they diagnose your dad immediately, or did it take some time?
Well, it was devastating because, first of all, we had to drop him off at the door. We could not go in with him at all. They would not let us come in at all with him. Shortly after he was there, they called and let us know that he was going to be admitted. Shortly after that, they called us several times, to let us know our dad had pneumonia. Then, an hour or so after that, they called and said, your dad is going to have to be put in ICU on a respirator. The next thing we know, the next call was, we did a test on your dad and he has COVID.
What do you remember from the hospital stay?
Right.
I don't remember anything.
So, and how long were you on the respirator for?
Ooh, for weeks, at least 4 weeks, for a while.
Wow.
He didn't know anything. He was just out.
So Joyce, for the family, it must have been really stressful.
Very, very stressful because doctors was calling And one of the calls was like, hey, who's responsible for signing the paper if something would happen to your dad? Would you want us to revive him? Or because he's now in very poor critical condition and we don't know if he's going to make it or not. At that time, my sisters and I went into a prayer, praying to God to save our dad. And one of the reasons is because we knew our dad had never really been in the hospital for anything serious like that. He's such an outgoing person. He's always been very active. He always acted way younger than what he really was. He's a fun person, active person. So it was another devastating moment to find out that he was going to have to go on dialysis. I think that sort of took Dad into a depression. He just didn't understand, and he did not want to be on dialysis. That was a big thing for him.
What has, your post-hospital stay looked like? So you're on dialysis. Have there been any other complications as a result of all this?
You have a taste.
Right. He's lost his appetite. He don't have a taste. He hadn't had a taste since he's had COVID. He's lost lots of weight. And it's so hard for me and my sisters or anybody to get him to eat more than 1 or 2 spoonsful of food. It's really hard right now as far as that.
And how often are you having to do dialysis?
3 times a week.
Mm-hmm.
Monday, Wednesdays, and Fridays.
Right. And are you seeing other clinicians as well? Are you seeing a number of different doctors for follow-up appointments and things like that?
Yeah.
Yeah, like Dr. Patel, your cardiologist.
Yeah.
Because once he got out of the hospital, he had to have surgery on his left leg due to blood clots. So he's still having complications from COVID, although he doesn't have COVID, but it's just what comes with it. Just like, for instance, my dad has never had a kidney problem, anything wrong with his kidneys or anything like that, but he has to be on dialysis, and we don't know for how long, hoping that, his kidneys will start back working, functioning correctly so that he can stop being on dialysis, because that's one of his downfalls that really puts him into depression.
With the hospital stay and family members and church members not being able to be there, you're communicating with your doctors and nurses,
right?
Via phone calls. But were there any nurses or doctors that really kind of went the extra mile for you guys?
His nurses were absolutely great in ICU. His lung specialist, his cardiologist. The crew at Baptist DeSoto was really, really good, especially in the ICU. And another thing that the nurses did that we were really pleased with, they let me FaceTime my dad. The ones that had iPhones, they let us FaceTime and let us see him and let him hear our voice, even though he was out of it. And they said that helped him a lot. That was good therapy for him. His music was good therapy for him. They allowed that, and they also allowed us to FaceTime him and talk with him and communicate with him and to try to encourage him to come out of this thing, to be strong.
Right.
And that was a big plus. So we really was appreciative of the staff for that. We sent them food, drinks, gifts, everything, because they were just so nice. They were very, very
You know how to get them on your side. Send them some food, right? That's great. Well,
and then after they heard his CD, all of them were singing his music as well. And then they started looking him up. We told him, hey, you got a famous patient here. They started looking him up on the internet and saw all the places he's been and all the things he's done. And I think his famousness helped him out some too.
And so how has your family kind of changed how it does things as a result of this? I mean, are you all like being really, careful about who's in the house and all that kind of thing?
He wears that mask everywhere, and all of us do. It has taught us a big lesson. The social distancing is kind of difficult for our family because we are a close family and we like to be around one another. So, only like Me and my two sisters would go visit him more than anyone else. Maybe one or two at a time. Grandkids will come, one or two at a time, but we never let him have a house full. We always keep it, 3 or 4 people.
Well, I want to thank you all for joining me so much. We are really appreciative for your time, and God bless you guys.
Daddy has a new CD that's coming out. The title of his new CD is entitled Trouble. So you guys be listening up for it.
All right, we'll do that. All right, thank you all. Take care. Thanks so much.
Thanks for having us. We enjoyed it.
Absolutely. It was great to talk to Reverend Wilkins and his daughter Joyce. They serve as an example for the challenges families across the country are dealing with due to the current pandemic. And for our first panel, we'll explore some of those challenges. I want to introduce Amanda Conchafter, Communications Director for the Alliance for Patient Access, who will lead a discussion about cardiovascular care during COVID-19. Amanda?
Thanks, Ryan. Good morning. I'm Amanda Conchafter with the Alliance for Patient Access, and it's my pleasure this morning to moderate a panel discussion about how the COVID-19 pandemic has impacted cardiovascular care. It's my privilege to welcome several panelists. First, Dr. Alana Morris, a physician, assistant professor of medicine, and a member of the Emory University Clinical Cardiovascular Research Institute. Dr. Jan McAllister, a board-certified adult nurse practitioner, a clinical lipid specialist, and a member of the Preventive Cardiovascular Nurses Association. And Tara Johnson, a veteran policy expert who currently leads the National Conference of State Legislatures Health Program. Thank you all for joining us this morning to share your insights and experiences. Now, in the past 6 months, we've heard some unsettling data about the impact of the COVID-19 pandemic on cardiovascular health. So just a few weeks ago, the Institute for Patient Access, which is a co-host of today's summit, released a paper titled Fear Factor, which explores how heightened concerns about coronavirus exposure led people to abandon care for chronic and even acute conditions. And prior to that, the Partnership to Advance Cardiovascular Health released a policy paper summarizing a series of phone calls among partner organizations where they reported and discussed in real time the challenges unfolding for the cardiovascular community. So Dr. Morris, I want to start with you. Can you tell us exactly how bad was the COVID-19 pandemic for cardiovascular health?
Yes, thank you. I think this has been a real challenge over the course of the summer, not only in the United States, but of course across the globe. I think we have to keep in perspective that the US is leading the world in terms of both number of cases as well as number of deaths. Over 200,000, I think as of today, we're at 207,000 deaths. And of course, a certain proportion of those deaths are due to cardiovascular deaths because we know that many of these patients are dying of cardiovascular collapse, if you will. Many of these patients are coming in with heart failure and the heart being the primary organ affected as opposed to respiratory failure or lung collapse as we originally expected when we first heard about this virus from China. And as you mentioned, we are seeing many of these cases of disease occurring because patients are avoiding interacting with the healthcare system, not only when they're experiencing symptoms of COVID, but also when patients have pre-existing conditions like high blood pressure, coronary artery disease, heart failure in the case of my patient population, and they just don't want to come in. I can tell you, particularly early on in the pandemic, we literally had to beg patients to come in to be seen because our patient population is so sick and so acute. There was really no way for us to completely close our clinic, and we were doing a lot of telemedicine visits early on, but we still had our clinic open, and patients would call complaining of shortness of breath, chest pain, and we would tell them that they needed to come in to be seen in person. And again, literally, we would have to beg some patients to come in because they were so afraid of coming either to the emergency room or even to the clinic to see their doctors. And we are now seeing reports in the literature of the effect that that has had on both morbidity and mortality. There have been reports in multiple states of the increase in, for example, acute myocardial infarction, patients coming in with heart attacks, late presentations of heart attacks because they sat at home with chest pain and shortness of breath for many days, and that has been associated with increase in mortality, earlier deaths that maybe could have been avoided. There was a recent paper that came out from the UK showing at least 2,000 excess deaths from March to June. That's about 17 deaths per day, and they were able to show in this paper that many of these patients were dying at home or in nursing homes as opposed to dying in the hospital. So again, we are seeing that not only is COVID-19 itself killing patients, but because patients are avoiding coming into our emergency rooms, avoiding coming into our hospitals, that we have seen excess deaths as a result of that.
So clearly it seems for a period of time at least, patients mistakenly thought staying home instead of going to the doctor's office or the hospital ER was the safer option. So Dr. McAllister, I want to ask you, do you think patients see things differently now?
I think over a period of time, patients have certainly grown a little more used to the pandemic and how to navigate the pandemic. Early on in the pandemic, I'm a part of Piedmont Healthcare System at Piedmont Heart Institute, and we're attached to the hospital. We had the same problem. We became an urgent care essentially for our patients who wanted to avoid going to the emergency room for angina, chest pain, pressure, shortness of breath. Now, compared to March and April, certainly more patients are coming in. We are doing less telemedicine than we were previously. But for a lot of our patients, there is lab work that is needed and certain interventions done in order to maintain their health. And when they don't come in an in-person visit, it's very difficult to deliver that care. Therefore, they come back sicker or come back out of control with their diabetes, hypertension, heart failure, so forth.
Tara, I want to come to you. What have state legislators done to help address the gaps in care during COVID? And what more could they do?
Yeah, that's a great question. And for some context for everyone who's joining us today, we have seen over 3,000 bills introduced in 2020 related to COVID-19 across all 50 states and the US territories. Almost 900 of them relate to health, public health, healthcare workforce, and state policymakers have a lot of policy options related to Medicaid programs and the infrastructure to increase demand for healthcare services. Regarding state efforts to improve healthcare during COVID-19, we've seen more than 20 states expand coverage for COVID-19 testing and treatment to uninsured individuals. And then Alaska and Washington allow coverage for certain out-of-state individuals. We've also seen several states, many states increase flexibilities to improve access related to telehealth, expanding allowable locations for services, or temporarily expanding criteria for qualified providers. All 50 states, Washington, D.C., and 3 territories have used 1135 waivers to allow health services to be delivered in alternative settings. For example, in Georgia, they requested flexibility to use mobile testing sites and other temporary residential arrangements. In New York, they enacted a bill to allow telehealth services to be provided through video-only communication or audio-only in limited circumstances. And in Kentucky, they allow for case management and most home and community-based services to be delivered via telehealth. Policymakers also considered temporarily eliminating or modifying existing licensure requirements. So we've seen at least 20 states have eliminated or waived cost sharing requirements for Medicaid services. A couple examples we've seen in California and Maryland are eliminating cost sharing requirements for certain low-income children, and 17 states have eliminated cost sharing specifically for individuals with disabilities. All 50 states have used a waiver in some capacity to waive certain provider licensure or certification requirements during COVID-19 and allow for out-of-state providers to work with patients in their state. These actions can certainly make it easier for people to receive that important routine care that you all are talking about, and mitigate some of the challenges with the pandemic that we're seeing. We do anticipate to see quite a lot more legislation in this area during the 2021 legislative sessions in states.
Thank you for that, Tara. And you mentioned telemedicine. If there's one issue we've heard more about during COVID than ever before, I think it has to be telemedicine. And so, Dr. Morris, I wonder if you might talk us through what a virtual visit is like for a cardiovascular patient, and what do you see as kind of the pros and the cons of telemedicine?
Sure. I think overall telemedicine has been extremely positive. It has really allowed us to see our patients in a way that we weren't able to before, because usually we were seeing patients on our terms in a clinic setting. And now we're seeing patients in their home settings. So it's allowed us a perhaps more intimate view. I think we are challenged sometimes because our ability to see certain touch points like a blood pressure or a finger stick glucose or a weight is dependent on whether or not patients have the ability to get those measurements for us. As a cardiologist, I clearly want to know what a patient's blood pressure is. But if a patient doesn't have a blood pressure cuff at home, or that blood pressure cuff is not working, that challenges me in terms of being able to make sure that they are meeting certain goals and certain metrics, or my ability to titrate medications. And certainly I would not want to manage a patient like that over a long period of time. And for me, as a heart failure cardiologist in particular, I really do want to be able to examine my patient. I want to be able to look at their legs to see if they have swelling. I want to be able to look at their neck veins, listen to their heart. And so I do think that for certain specialties, particularly within cardiology, there is a need to see a patient face to face. So I think, again, overall telemedicine has been incredibly positive. I think there's clearly a convenience for patients that probably can't be beat. Certainly coming into a doctor or nurse practitioner's office and waiting sometimes for hours to see us can be very inconvenient. But I do think that we often need to see a patient face to face in order to really get a good assessment and be able to continue to make sure that risk factors are well controlled. So I'm not sure that telemedicine will replace face-to-face care ever. I hope that it won't.
Right, and that's the explanation I think we hear a lot, is that it's a powerful complement to in-person care, but never meant to be a replacement for in-person care. So, with telemedicine, we saw insurers, both private and government, being a little more lenient during the pandemic. Some covered telemedicine for the first time. We saw the Centers for Medicare and Medicaid Services cover audio-only telemedicine visits, so telephone visits, essentially, which can be important for people who may not have access to a laptop or a smartphone, or may just not be comfortable and confident using that technology. But Dr. McAllister, I'm curious, did this flexibility extend to other aspects of insurance coverage for cardiovascular care outside of telemedicine?
So that is a great question. And it was also a source of a lot of my frustration during this pandemic. I did find that there were several insurers, payers that would extend prior authorizations. There are many, many cardiovascular drugs that require prior authorization approval through the patient's insurance in order to get their claim paid for. And I specifically deal with a lot of these medications, and once a year they need reauthorization even if they've been authorized. So some of the payers were great, and they extended a prior authorization if needed a couple of months automatically. during this pandemic, so you didn't have to do it right in the middle of the pandemic, which required patients had to have lab work within 3 to 1 month of when you were applying for the reauthorization or the pre-authorization. So that was great. But it just so happens that CVS Caremark, which is a pharmacy benefit manager for several insurance payers, sent out a letter probably about April or May to their patient population. And actually, patients who were on one drug for this certain class of PCSK9 inhibitors could have been on that drug for years, been totally stable on the drug. They have changed formulary as of July 1st. And regardless of what they were on previous, regardless of where their numbers were, if they tolerated the drug, CVS Caremark decided through their payers that they were going to change formulary and they were not going to approve the other drug. Even if they haven't had a problem on it, they had to switch drugs, change over to the new drug. I had to do the paperwork to get a prior authorization done. On top of all the other paperwork I was already doing for cardiovascular patients that were coming in with COVID, half of the patients didn't even get notification letters from their PBM or from their payer. And I'm still reaping repercussions from that July 1st switch over, where certainly patients were not an example of how can we take care of the patient first and fill in the details later. It was certainly a cost-effective approach for them to save money. So that was certainly not the best example of how we need to really improve access to all of our patients and keep them as a top priority.
So that's interesting. So the type of switching you're referring to, we hear that called non-medical switching, essentially where you have a stable patient who's then required to change medications because of some logistics with the insurance company. Generally, the idea that the insurance company can save money, though what we often see is that it ends up being problematic, even dangerous for the patient, and actually more expensive often in the long term because of extra labs and doctor's appointments, sometimes even ER visits that are required. So sounds like telemedicine may have been a little easier to implement, but other elements of cardiovascular care got more complicated. And it's interesting because of something I want to add in as well. So we hear the long hauler effect talked about more and more. This is essentially when people who had a chronic condition already, then contracted COVID, and then are now dealing with new or heightened conditions. So things like chronic fatigue syndrome, for example, or an inflammatory illness. That makes it even more difficult for them to manage their original condition. So Dr. Morris, I wonder if you can just briefly give us a sense from a clinical perspective of how treating a chronic condition becomes more difficult when you add other chronic conditions on top of it.
Sure. I mean, this is a real challenge. You heard in our video segment earlier about a patient ending up on dialysis, for example, which is a very intensive therapy. Certainly, I think people are happy to be alive, happy to survive COVID. But surviving COVID and ending up on dialysis 3 days a week can make a substantial impact on quality of life. Having to have family members drive you to dialysis center 3 days a week. And all of the complications that can come along with being on dialysis, on top of, for example, maybe already having had a heart attack in the past or having diabetes and high blood pressure. These things can start to compound and really make quite an impact, not only on the patient, but stress for their caregivers in addition. And many of our patients are already dealing with chronic fatigue, as you mentioned, chronic symptoms of chest discomfort or chest pain, shortness of breath. And then when they have lingering symptoms from this long hauler effect that add to those symptoms of shortness of breath, those symptoms of fatigue, it can be very, very challenging. It can really limit their functional capacity, limit their quality of life in a way that makes it difficult, again, for them to tell, is this my heart failure? Is this the long hauler effect on top of my heart failure? And we see patients, again, sort of going to the emergency room, trying to figure out which is which and how to manage those symptoms. And it can be a real challenge, again, for the patients as well as their caregivers. And I think we, as the clinicians taking care of these patients, as well as the patients and their families, are still trying to adjust to this new way of life, this new normal.
Well, I'm told we have time for just one more question. So Tara, I want to end with you. So our conversation this morning has made a couple of points clear. First, that things got pretty bad when patients weren't staying on top of their conditions, weren't seeking medical care that they needed, but also that as patients get back on track, start resuming regular care again, we could discover that cardiovascular health is in fact worse because conditions have advanced, because of issues like the long hauler effect, and then potentially another spike in COVID cases this fall or this winter. Do you think policymakers in the states see this coming? And do they have the policy solutions at hand to address a population that could conceivably be less healthy than it was when this pandemic first started?
Yeah, thank you for that question. It's a really great question. And I can say that a lot of policymakers that we've been working with at NCSL, over the last month, we've had several meetings related to COVID-19 over the last month, and they're very aware of the possibility that people's health may be worse after COVID or later in this pandemic. And they're concerned about it. And we've heard this from Republicans, Democrats, independents, everyone across the board. I think one of the big challenges, which many of you may be aware of, is that every state is anticipating a revenue decline in the next year. Reports are ranging from 5 to over 20% of a decline, which really will make a substantial impact on some state budgets. And Medicaid accounts for, on average, 20 to 30% of state budgets. So legislators are going to have their work really cut out for them this next year on balancing budgets and enacting legislation in response to COVID-19. Had that being said, I would say that maybe not all state legislators are aware of this, especially ones that aren't on health committees. So I would highly encourage all of you as experts to reach out to your representative or senator, let them know you're a resource for them, and start that communication with them early, so when some of these bills do come up in the 2021 session, you can be a resource for them. We certainly anticipate some states considering solutions such as promoting health and wellness programs, reducing health disparities. We've seen several states introduce legislation this past year and anticipate more in 2021. And state legislators, of course, they can provide funding, but they also can convene partners with the public health community, the healthcare community, local leaders, and can really bring people together. So we anticipate seeing some of that over this next year related to COVID-19. Again, many of you know there's a big election coming up. So there's about 6,000 seats up for election in state legislatures across the country. I would say definitely pay attention to that in your state. And if you are interested in reaching out to your state legislator, I would recommend doing it after the election, but before the 2021 legislative session starts in your state.
Thank you, Tara. That's good to know. I want to thank our panelists this morning, and we'll now wrap up with a video from the Partnership to Advance Cardiovascular Health on the topic of telemedicine.
Unexpected events can interrupt people's lives. They may also interrupt their health care. And for people living with diabetes or cardiovascular conditions, that can be dangerous. Telemedicine provides a lifeline, keeping patients and healthcare providers connected during turbulent times. And it's simpler than you think. Using your smartphone, tablet, or laptop, you can have a virtual consultation. Just you and your provider. Prefer low-tech? Telephone check-in calls are also now available for some patients. Need a prescription or refill? Your provider can submit the request electronically on your behalf. Whether it's a regular check-in or timely advice on acute symptoms, Telemedicine gives you one-on-one time with your healthcare provider without having to travel to a clinic or hospital center. Patients can face many unknowns: a public health emergency, an economic downturn, or a change in conditions at home. But one thing is clear: the need for people with diabetes or cardiovascular conditions to stay healthy and stable is as important as ever. So don't hesitate to ask your healthcare providers about telehealth options. They can walk you through it. Learn more at advancedcardiohealth.org.
So, Linz, I had the opportunity to actually talk to another patient who has dealt with statin-related side effects and high cholesterol for her entire adult life. And she and I actually live in the same state, so I got a chance to meet her, socially distanced, of course. And she has such an interesting story because she's a patient, but she's also a doctor. So I want to start the next panel with a video that we cut of her, and then Jasmine will lead our next discussion on the next panel.
Great. I know we're really excited for the debut of this video.
I grew up on a farm that my father had where he had polled Hereford cattle that were breeding stock, but he also was a surgeon. His patients would come to the farm and they became an integral part of our life. My father would take us with him in the car, but he would make rounds on people out in the country, and we would get out and play in the yard with those people's children or grandchildren, and we'd sit on the porch. I think it taught me several things about being a physician, and one was my father's connection to these people was far more than just being their doctor. He considered many of these people his friends, and they considered him a friend. My family does have a history of heart disease. My grandfather died quite young of a heart attack. My father had heart disease, but much later in his life. I realized I had high cholesterol in my late 40s and started taking cholesterol medication, statins, in my 50s, and then ended up with a bypass when I was 57. When I was on the statins, I would gradually get muscle cramps. I'd wake up at night with muscle cramps, and during the day, just sitting, I would have muscle cramps, and then it would just hurt all the time, particularly in my back. The cardiologist that was the head of the department said, well, you just have to put up with it in order to get the benefit from the statins. And I think that's someone who doesn't really think too much about their patient's experience. You know, they talk a lot in medical school about the patient interview, where you learn to interview the patient. Well, I think doctors who are quite skilled end up making that interview so personal that it's a conversation. You have to be able to connect with the patient. I mean, you can know all the stuff in the world, and if you don't listen to what they have to say, it's worthless. And that puts the patient at much higher risk. They'll say, you know, I'm just not going to take it because I'm miserable. And I'm not being offered anything else.
When it comes to healthcare, nobody wants to be treated like just another patient. We each have our own experiences, health history, lifestyle considerations, and responses to treatment. Perhaps that's why the call for patient-centered care continues to grow stronger every day. We know that positive health outcomes rely on personalized care. With heart disease prevention, we have adequate tools and research-backed data to show what's possible, but as a nation, we are not keeping up with guideline-based care for a variety of reasons. Today, I'm honored to welcome Dr. Anne-Marie Navarre, who, by the way, recently transitioned from Duke to University of Texas Southwestern. Big congratulations to you. Dr. Michael Shapiro from Wake Forest Baptist Health, and Dr. Elizabeth Gamble, who is a retired physician living with high cholesterol and whose story we just watched. Thank you all for joining today. Dr. Shapiro, I've known you for several years now and have also had the opportunity to work alongside so many of your patients. And honestly, a common saying I hear from them is, Dr. Shapiro just gets me. He saved my life. So from your perspective, what does patient-centered cardiovascular care look like?
Well, thanks, Jasmine, so much for providing the opportunity to speak about this really important subject today. I think that in cardiovascular medicine, we're very lucky because we have so many large studies with definitive evidence that allows us to inform care in many instances. And we certainly have excellent guidelines that help providers in making these recommendations. But if we only needed guidelines, we could have computers or robots do our job, of course. So, there's the human element, and that's what it's really all about. From my vantage point, I think patients come to see us because we have a certain knowledge, a certain expertise, and I really see my role as a guide or as an educator. So I can tell patients what the evidence shows. We can talk about the various options. But beyond that, really their values, their life philosophy and other practicalities really have to guide the conversation and the decision-making process. So I believe I help them navigate that path. And to me, that's really what patient-centered care is all about.
Absolutely. Thank you. And Dr. Navarro, what about you? Shared decision-making is integral to your relationship with your patients as well. So would you like to add anything here?
I really agree with Michael. I think that the analogy about guidelines and being a guide is really good. You think about where the word guidelines come from. If you're hiking on a mountain, you've got these sort of ropes that go along and help show you the path. Most of the time, that's the way to go, but sometimes it's not. There's changes or patient-specific situations where you need to veer from the guidelines. So the guidelines are a place to start, but may not be the right fit for everybody. And I think my job as a physician is to sort of be a guide and to understand the environment, understand the lay of the land for the patient, which involves their experiences, their preferences, what their goals are for their overall health, and then help work together to find a path to get there. You asked what patient-centered care looks like, and I think really it's more of what patient-centered care sounds like. And it sounds a lot like, listening to the patient, hearing what they want, hearing about what their experiences have been, and then communicating options and coming up with a path together.
I really like that. What does patient-centered care sound like? So I want to loop in Dr. Gamble here. First of all, great video. That was really beautifully done. And also, I just wanted to thank you for putting on your patient hat here. This is a very important conversation. So I loved hearing about how you grew up seeing your dad. Oh, thank you. So I loved hearing about how you grew up seeing your dad be so involved with his patients and how that really shaped your becoming of a trusted clinician to your patients during your tenure. And one of the messages I took away from your video was to just keep trying. And being someone who is intolerant to high-intensity statins, you explained how your cholesterol-lowering journey with statins was trial and error, and in particular, very focused on dose management. So can you dive a bit deeper into that experience? And really, I'm asking this question for people who are dealing with similar issues and need some encouragement.
I think the first thing about dealing with it is to keep trying, and if you don't get an answer that you like from the physician or the advisor or the caregiver that you're dealing with, is to seek an answer somewhere else, which is what I ended up doing, having struggled for years with my cholesterol, with dose and modifying things like enzyme Q10 and exercise that didn't really help that much. I certainly found that when I was added drugs for another disease and my cholesterol went up, that I needed more advice. And so I asked my primary care physician to help me with that. And he suggested I go to Dr. Shapiro, which turned out to be really a godsend for me.
Yeah, and so as you said, Dr. Shapiro is now your cardiovascular specialist. And in the video we just watched, you said that the head of the cardiovascular department didn't quite listen to you. And I'm sure that was very trying for you, especially the fact that you were a physician yourself. So how is your relationship with Dr. Shapiro different?
Well, I think that he's much more personable, and certainly on our visits, he treated me as an equal. He listened to me with a non-judgmental attitude and basically was able to come up for a plan that was very helpful. Just to defend the department chair from years ago, there really weren't alternatives at the time, but now we have good alternatives.
Right. Right. Thank you so much. So Dr. Shapiro and Dr. Gamble, this is really a perfect example of what success looks like when it comes to serving as equal in patient-centered care. So I hope your experience can inspire patients and clinicians to navigate their relationship similarly. Now, Dr. Navarre, some people look at a condition like high cholesterol and say, individualizing care for every patient, it just isn't realistic, and high cholesterol is too big and too widespread. So how would you counter that argument?
Well, I think that individualizing care doesn't have to be complicated. Individualized care for many patients may be the same thing. The guidelines recommend for people with established cardiovascular disease to start on a high intensity statin. Folks who are at high risk for heart disease can start on sort of a moderate to high intensity statin. And I would say that 90+% of people are able to tolerate that. And so, personalized medicine for them just means explaining to the patient what the recommendations are, making sure that their goals around prevention are aligned with what the guidelines would recommend, and that they understand why we're lowering their cholesterol, and then things are fine. I like to give my patients a little bit of a warning, sort of say that not every most people are going to tolerate this, but you're not most people, you're you. So if you have trouble tolerating it, or you think you're having trouble tolerating it, let me know, because there's other options. So if you tell people in advance, you might not tolerate this statin, but there are other statins, there's other doses, there's other dosing intervals that we can use. Sometimes it feels a little bit more hopeful if they start to experience side effects, and then they're more likely to tell you about it, rather than just stop the medication and hope you don't notice. So I think personalized medicine really means giving everybody the opportunity for personalization, but recognizing that maybe it's not going to be needed. And if you're one of the lucky people who can tolerate the first statin on the first go around, then personalization means that you may be getting the same thing that everybody else is, but it's actually the thing that you and everybody else needs.
Right. Dr. Shapiro, any comments?
Yeah, I mean, I completely agree with Dr. Navarre. I would just add that, we have to understand that prevention of cardiovascular disease can really occur at many scales. At the population level, there's certain general recommendations and interventions that can improve the overall health of the population. And some of these recommendations are implemented through regulatory policy. And there's some specific examples like banning trans fats, increasing the cost of tobacco products, a sugar tax, and so forth. And, put another way, that's, like saying a rising tide lifts all boats. On the other hand, Dr. Navarre and I specifically see patients at very high risk for cardiovascular disease. And at that scale, we can be much more specific and aggressive about certain recommendations, including medical therapy for cardiovascular risk reduction.
Right. Dr. Navarre, you're very passionate about this topic, so I'm just going to pivot back to you here. Statins are, as you said, they're overwhelmingly efficacious. They're time-tested therapy, globally accessible, and today the first-line treatment option for individuals living with high cholesterol who cannot effectively lower their levels with diet alone. However, statin-associated side effects are real, and I think it's important to talk about this because, again, LDL lowering should be person-centric. So can you please distinguish between true statin-associated side effects and the dangerous myths that continue to circulate on Dr. Google, as we all call it, and scare people away from statins?
Absolutely. So the first thing that I want to address, probably could have addressed in the last question, is how the paradigm has really changed for how we use cholesterol-lowering drugs. So it used to be we would think about only treating people who had high cholesterol, thinking about high being sort of at a population level, in the top 10 or 20% of all people. What we've actually learned over the last 10, 20 years of research and hundreds of thousands of people is that even lowering cholesterol in people who have normal, or what we would have even previously thought as lower cholesterols, continues to give benefit. So one of the things that I do is think about using cholesterol lowering medications, not just to treat high cholesterol, but to lower heart disease risk. But the truth is that a lot of people do experience side effects on statin therapy. If we look at clinical trials, so randomized trials where we give half of people a statin and half of people a sugar pill, most people cannot tell the difference. And in fact, in studies with thousands and thousands of people, the rates of things like muscle cramps and muscle aches are actually fairly similar. There's only about a 1 in 10,000 person risk of really severe muscle damage from statins that we can see with a lab test. But what we see in clinical practice is about 1 in 3 people are feeling side effects that they attribute to their statin therapy. And it's really hard if you're one of these people who is feeling these side effects to know, is this from my statin or is this from something else? And it's even harder because there's so much misinformation out there about statins. So if you go to Dr. Google or look on various websites, there's a lot of misinformation about statins. There's information that they cause memory loss, cause huge rates of muscle aches, cause muscle weakness. And in real clinical studies, that is not true. So statins do not cause muscle weakness. They do not cause memory loss. As I mentioned, the risk of muscle problems is about 1 in 10,000. But what a lot of people experience is sort of a placebo version of a side effect, where the fear of the side effect drives them to feel it. And from my perspective, it's not quite so relevant to me if they're one of the unlucky people that is experiencing true biologically induced side effects, or if they're one of the people who is experiencing one of these nocebo effect or a placebo side effect. Because from the patient perspective, it feels the same. And it's incredibly unpleasant and it affects their quality of life. So regardless of the reason, we have to do something about it. Now, the good news is that most people who don't tolerate one statin at a certain dose can tolerate a different statin, often either at a lower dose or a different sort of like every other day dosing. So I treat all of those side effects as if they're real, but don't give up on the statins. We don't throw the baby out with the bathwater. And then the other thing that we really need to work on is preventing this just absolute epidemic of misinformation. We're seeing it with COVID. We saw it with vaccines. And I was sort of horrified to see that a lot of the sites that pushed the initial anti-vaccine rhetoric are now pushing anti-statin rhetoric. And I would just caution the audience when you see that is to look for the agenda, because a lot of the times that these places are sort of anti-statin or anti-vaccine, they're selling you something. They're selling you a subscription to a newsletter, a natural alternative, some nutraceutical or fancy diet book. And so they're using a fear of statins to sell an alternative which has not been proven or trusted. The truth is that statins, all of the statins that we use are generic. They're very cheap for patients. Even without insurance, you can get statins for $3 to $5 a month. And doctors don't make any money for prescribing statins, but we keep you healthy. So we need to do a better job at addressing the misinformation, at teaching our patients and even our colleagues how to assess what quality information is. And I also urge my patients to stick with really trusted sites like the American Heart Association, American College of Cardiology, American Society of Preventive Cardiology, these sort of professional organizations who don't have a dog in the fight, but really just care about the health of Americans and people worldwide.
Thank you, Dr. Navarro. It's very important to address that. So for our final question here, the American Heart Association and the American College of Cardiology, as you mentioned, they regularly release guidelines that give us evidence-based recommendations on how to manage high cholesterol in the United States. Studies show that these guidelines are oftentimes not applied into clinical practice as intended due to a variety of barriers. So I'd like to ask each of you this question. In your opinion, what are 1 or 2 obstacles that slow guideline implementation, and how do we address them? So we have about 4 minutes left here, and I'd like to start with Dr. Shapiro.
Yeah, this is an incredibly important point, Jasmine, and it's really fully expected that with the fast pace of evidence generation that it takes to create a new guideline, that the moment the guideline is published, it's already out of date. So really, to me, guidelines are incredibly useful, but reflect a minimum standard by which we should be helping our patients. They're particularly useful for the busy clinician who's dealing with a lot more than just cholesterol management. But even for busy practitioners, it's so difficult to keep up with all the different guidelines that are available. So that's one issue. There are many others, but I would stress the fact that our payer system doesn't always endorse the same kinds of things, the same recommendations that our national guidelines do. So sometimes there's this tension in trying to follow through with the guidelines, but also prescribing medications that are affordable for our patients.
Thank you. Dr. Navarro, please go ahead. And then Dr. Gamble, please feel free to answer right after. I know you can give us an interesting perspective.
It's really a golden age for prevention. We have a number of new therapies that are approved and available beyond statins to lower cholesterol. Injectable PCSK9 inhibitors, a new therapy that's a pill called bempedoic acid, and a couple of therapies in the pipeline. But it has been really hard as a clinician for me to get patients on those therapies when they're eligible. So either people who can't tolerate statins or people who still need LDL cholesterol lowering after statins. And a lot of that is due to barriers. It takes a lot of time that is uncompensated to navigate a prior authorization process. We have to submit forms over and over again. It's frustrating for both the doctor and the patient. And then patients are hit with these crazy copays, either upfront or once they hit the donut hole or the coverage gap for those who are on Medicare. We have to do better, both in the process to get approval for therapies that patients are eligible for, but also in both health policy reform and insurance coverage that addresses both drug pricing and patient copays, and having a system of care that your finances just are not a barrier for our patients. I think if it was easier for us to get patients on the right therapies, we would have more patients on those therapies. And it seems really obvious, but it's a huge barrier, particularly for the new treatments. And it's really disappointing because all the work and all the science that goes into developing new therapeutic options fall short if we can't actually prescribe them for our patients.
I totally agree with what you've both said, but come from a little bit different perspective. Certainly the search for the magic bullet that will cause behavior change in practitioners has been long sought in many different levels. Most studies show that both CME and other methods of trying to improve doctor adherence to current guidelines has said that they don't work. And currently it's estimated that anywhere from 10 to 17 years is the time period it takes from the bench discovery of a new therapy to it going to a guideline and then being implemented by a local physician. In North Carolina, where I live, there is a group called Community Care of North Carolina, which is funded through Medicaid, and it aimed to improve both healthcare and decrease costs of healthcare in the Medicaid population. And one of the things that I did was visit offices frequently, become known by the offices, and would help them educate them on current practice guidelines and help them work through challenges to do that. And I found that the soft touch approach and the familiarization with knowing me and knowing they could trust me really helped improve move to practice guidelines. So I think physician change of behavior is an important component of this also.
Thank you all for your time today. This was an extremely important panel. We really appreciate your participation.
Thank you.
So, Lindsay, what are your wrap-up thoughts here?
Well, just what a great panel of experts. I think that it just shows that we really are on this fast track to precision medicine, but it just seems like the policies are slowing us down. So I think they really brought life to that.
Right, absolutely. Thank you. So we're going to pivot now. When we do this summit in person, this is the time where we take a step away from the deep dive policy discussions, allow everyone to grab lunch, and we have a speaker who talks about cardiovascular disease from a slightly different perspective. Our first year, we had Mark McEwen, someone many might be familiar with as a newsman and stroke survivor. Last year, we had Sandeep Johar, a cardiologist and author of Heart, a History, about the history of heart medicine. For today's keynote interview, we are honored to have Betsy McKay, a reporter at the Wall Street Journal. Betsy covers U.S. and global public health issues for the Journal and has spent the past few years covering America's heart disease crisis. Ryan will lead this conversation.
Betsy, welcome. We're really thrilled to have you here for our virtual lunchtime interview.
It's great to be here. Thank you, and bon appetit to everybody who's eating lunch while we're talking.
Absolutely. So, Betsy, I have to tell you, you're one of the reporters I follow on my Wall Street Journal app. I cite your work all the time in presentations that we do on the cardiovascular crisis we are seeing in America. But to kind of level set and get us started, I'd like for you to give us an overview of your career as a journalist, and I'll kick off that discussion by asking you how did an Amherst grad become a reporter for the Moscow Times, write about the post-Soviet political and economic transformation, and then become a global health reporter? Like, walk us through that career path.
Yeah, it's an unusual career path, right? A lot of people just start one career and that's what they do. Well, in college, at Amherst College, I majored in Russian, and I was editor of my college newspaper. So, of course, that eminently qualified me for what I really wanted to do with my life, which was to be a journalist in Russia. So it took me a few years, but I eventually got there. I went to graduate school first, and I ended up as a correspondent in Moscow for the Wall Street Journal. I started with the Moscow Times. I helped start that newspaper first, which was a local English language newspaper for expats in Russia. And then I started my career. I moved over to the Journal and started my career there. So after many years of being in Russia, I had a family. We wanted to return home. I came back to the US, and because I worked for the Wall Street Journal, I took on a corporate beat, and I covered the soft drink industry for a few years. As you might imagine, at that time, the early 2000s, a big issue in the soft drink industry was increasingly becoming health, and specifically the obesity epidemic and diabetes. And I started writing about that and sort of worked my way into covering health from there. We had a health beat open, needed someone to cover it, and I created a public health beat. So since then, that was many, many years ago, I have covered two things really: epidemics, which makes me very busy right now, and epidemics of chronic diseases. So epidemics of infectious disease and epidemics of chronic disease, such as heart disease.
So, and you might have actually answered this question, but why is cardiovascular disease of particular interest to you as a journalist?
Yeah, well, so I cover public health is my beat. And, in public health, we're looking at the leading causes of death, and heart disease and cardiovascular disease overall are the leading cause of death. So I have spent time kind of looking at what are, the sort of underlying causes of changes going on in the death rates. And, when you look at the effect on the population, certainly public health approaches, the war on smoking and stuff have had a greater effect on death rates than some individual approaches. So I kind of got into it from that lens.
So let's lean into that a little bit. So obviously you've been busy covering the coronavirus pandemic, and I actually, though, want to touch on some of the work you did before COVID became the story of 2020. So let's talk about a piece you wrote in 2019 titled, America's Biggest Killer Makes a Deadly Comeback. So in this article, you talk about one of the great public health stories of the last century was the monumental decline of death from heart disease and strokes. And you talk about how medications, procedures, and smoking cessation campaigns all contributed to that success. But the twist in the story is that in 2011, we really saw an inflection point in the data. And a lot of that progress that we saw from 1950 to that point is now reversing. So can you just explain at a high level what's going on?
Yeah, no, it was really startling when we first, I started looking at CDC mortality statistics, and I have to give a shout out also to Stephen Sidney at Kaiser Permanente Northern California, who's done a lot of research with these data. But it was really striking, and many people watching this have probably seen the same graphs that I have. You have this peak in the 1950s and a sharp decline, more than 70% over 6 decades. And then in 2011, it just stopped. And for the population overall, it has the heart disease, cardiovascular disease death rates have continued to decline, but just barely. I mean, it's like 4% over 6 or 7 years. And, nobody really knows exactly why 2011. I have, wanted to find out why 2011 versus 2009 or 2012, but what is clear is that the declines have stopped. And that's actually one of the factors behind our worsening life expectancy over the past few years. In 2014, life expectancy for the US stopped declining, and it kind of bounced up and down. And every year it goes up and down a little bit, but it's not getting better. The other thing that's not happening is that cancer was expected to overtake heart disease as the leading cause of death by now. And that's not happening because of this change. So, and the final thing is that while the death rates have been declining for the heart disease death rates, cardiovascular disease death rates have been declining for the population overall, they're actually going up in middle-aged people. And that's what I really focused on. So the 45 to 64-year-old group, they're up since 2011 about 1.5%, which doesn't sound like much, but it's a lot of people. And so then the question is, well, what's causing this? What are the drivers of this? And it really appears to be that the obesity epidemic and diabetes, type 2 diabetes, which as you know, goes along with it, seem to be the main drivers. And the thought is, there's a lot of research in this area. Certainly people are also looking at things like stress and other lifestyle factors which may be contributing, but the effect of the obesity epidemic really does appear to be the main one. And if you look back over 20 or 30 years, obesity has been started climbing in this country and around the world also in the 1980s. Diabetes in this country, the rates started climbing in the 1990s. It's interesting, you just see the lag. But in those years, in the 1990s, 80s and 90s in particular, there were a lot of interventions, medical advances that came to pass that sort of helped offset the possible effect of the obesity epidemic. Certainly the introduction of statins, right? The other issue is that it does take a while for the effect of chronic disease to start to have an effect, right? Diabetes or the effects of obesity. So anyway, those things all seem to have come together to 2011, and there really isn't much progress since then, and things are continuing to get worse. We'll probably talk about this in a bit, but I think going forward, certainly the pandemic is not helping that picture, and probably will worsen it.
So I actually want to talk to you about something you just mentioned about in the 1980s we had these new medicines, but in one of the articles you've written, you talk about how we need new tools and approaches, or heart experts need new tools and approaches to combat the current problem. So can you talk to us a little bit about what specifically heart experts, clinicians, public health experts are talking about when they are, specifically, what are they talking about when they say they need new tools and approaches?
I think one of the main points, as you all probably know so much better than me, is that it's been difficult to find new tools and approaches to address this problem, and that's one of the challenges going forward. So the past 60 years, from the 1950s until a few years ago, you saw the fruits of low-hanging fruit, getting people to stop smoking, better health and exercise, the overall health picture improved, more exercise, better eating, enough to certainly improve, and all these medical advances. Now we're talking about having to address the obesity and diabetes epidemics. And while there are medical interventions, as better drugs for diabetes, new cholesterol-lowering medications, work on lowering triglycerides, what you really then come to is having to make behavior change. And that's something I've tried to focus on in my writing, community approaches to reducing obesity, building sidewalks, getting people walking. All this is really hard and takes a lot of time. And so it's at the point where it's kind of gotten to that point where to really move the needle forward, you either need some major medical breakthrough, the next statin, or but probably more likely in combination with you need changes in behavior and changes in eating, changes in diet. I'm sorry, and as you know, that is so difficult right now because the default food choice in this country is food that's not necessarily healthy for you. So I think that's when I talk to people, those are the challenges that they talk about. The other obvious one is access to healthcare. I mean, people just coming in way too late. One thing I want to look at and had planned to look at more this year until we all got busy with something else going on, was just the incredibly high rates of and intractable of uncontrolled high blood pressure in this country. I mean, it is just unbelievable to me that the rates are this high. They don't seem to get much better, and there is safe and very cheap treatment. And so the healthcare system and the public health system getting its arms around that would make a big difference. But the fact that people aren't able to get the care they need, don't have access to it, are some of the issues that you all are facing.
Absolutely. So let's pivot a little bit. We've got about 2 minutes left here to talk about the current situation on the coronavirus because you've done exhaustive reporting on this. We've talked some today about how devastating COVID can be for patients who had existing cardiovascular disease or metabolic conditions. But can you tell us a little bit about the latest with patients who don't have cardiovascular disease? They do contract COVID, and then they see cardiovascular disease symptoms. You write that some COVID patients are even coming to the hospital thinking they're having a heart attack. So what's going on there?
Yeah, it's interesting. In the spring, I started writing an article about how the first point that you made, which is that people with pre-existing conditions like cardiovascular disease were having a tougher time with COVID. And as part of reporting that, I realized, well, there's two things going on. That is true. They have, they just have weakened immune systems because they're already fighting one chronic disease. But the other thing is that the virus actively attacks, the effects of the infection actually have also an effect on the heart and the vascular system. And this is affecting not just people with existing heart disease, but the full range. And it's, there's a lot of study going on to try to figure out who's affected and who's not. But there appear to be two issues. One is that some people mount a very aggressive immune response to this virus. And as part of that, the inflammation does damage to the cardiovascular system, the heart and the vascular system. The other is that the virus itself certainly attacks endothelial cells, also believes it directly attacks the heart. So you've got a constellation of factors going on. The latest finding is actually really scary. Even people who don't have heart issues, were only mildly ill, or maybe not even very ill at all, didn't even know they were ill, are turning up with scarring and heart damage. And what is this going to mean going forward? You could potentially see, depending on how widespread this is, you could potentially see a new cohort of people who need treatment and care long term.
So we're almost out of time, but I want to get your big thought to end our discussion here. So, cardiovascular disease is a silent killer. And a lot of times people may not know they have cardiovascular disease until they suffer a heart attack or stroke. But with the COVID crisis, we've seen that topics like underlying metabolic conditions like cardiovascular disease, diabetes, have rapidly risen in the public consciousness. I think another good example of this is racial disparities in outcomes, because COVID has just been so devastating for Black Americans. So my question is, do you think that the crisis causes or will cause a paradigm shift in how we think about and prioritize health, cardiovascular health, and healthcare? Or do you think that we get a vaccine and then things will just kind of go back to normal? What's your big thought?
I think that's everybody's fear, is that we get a vaccine. Everything is not going to go back to normal. But one of the issues is, okay, what are we going to change after this pandemic is over? What permanent changes are we going to make to prevent this from happening again? And what are we not going to do? I think in terms of what you're talking about, the risk is that all of the money and attention goes to more direct pandemic prevention, building early warning systems, more research on the effect of viruses, more work on vaccines and drugs for infectious diseases. And that the second issue, which is strengthening the healthcare system, that not enough happens there. But that said, there is a lot of, this really has cast a spotlight on two problems in our country. One, a sort of broken or hollowed out public health system, which has an effect for people who need access to healthcare. And the second thing is the healthcare system itself. So this pandemic has made clear that people who do not have access to healthcare suffer worse outcomes. And one would hope that going forward that will be addressed.
Absolutely. Well, Betsy, I just want to say thank you so much for joining us. We get the opportunity to talk to all these amazing clinicians and patients all the time, but for an advocate and someone that cares about these issues, it's so nice to have somebody, in the public media talking about these issues. So you're spreading a ton of knowledge out there, but we also get to take it and spread it to our audiences as well. So thank you so much for your work and for joining us today.
Thank you. I'm very happy to be here, and we'll continue writing about these issues.
That's great. Thanks. So to our audience, we'll be taking a 10-minute break so you can stretch your legs, and we'll be back here in 10 minutes and to go to our next panel, which will be on advocacy in 2021. You don't want to miss this. So stretch your legs. We'll be back in 10 minutes, and thank you. Welcome back to our studio here in Washington, D.C. What a great two first panels of the Cardiovascular Health Policy Summit. I do want to say we apologize we haven't had a chance to get to audience Q&A. We've had a number of good questions put into our system, but we haven't had time to get to them. But we're going to try to correct that on this panel. Hopefully we can get through our questions for the panel and get to the audience Q&A here at the end. So for anyone that follows health policy or politics, 2020 has been one of those years where the two have collided with enormous momentum. We have a pandemic, social unrest, and a presidential election all happening at the same time. It can make a confusing and difficult to navigate environment for heart patients, advocates, clinicians. And so today we've brought together a panel who will help us sort out what is going on and help provide some framework for what 2021 might look like and where advocates should focus their efforts. We have a lot of panelists for this discussion. Matt Kazan from Avalier Health, Kevin Kirby from the Moran Company, Frank Ryan, Senior Advisor for State Government Affairs at the American College of Cardiology, and Emily Holubowicz, Vice President for Federal Government Affairs at the American Heart Association. First of all, though we're in the midst of a presidential election, we're not going to be taking sides on this panel. What we are attempting to do really is to get below the headlines that you see in the media and suss out where there are opportunities for advocacy and how we can make sustainable change for cardiovascular patients. So, to the headline. Let's get started with the headline. March 13th, President Trump declares a national emergency. On March 13th, at that time, we had 1,600 cases of coronavirus in 47 states. A couple of things happened relatively quickly at the legislative and regulatory level. First, we saw the Centers for Medicare and Medicaid Services, CMS, infuse the public healthcare system with a lot of flexibility. And we saw legislation like the CARES Act signed into law. So Matt, I want to start with you. You've worked on legislation at the Finance Committee for years in the Senate. So in your mind, I would like to know, what was the most significant change to come out of the various pieces of legislation that were passed that could benefit cardiovascular or chronic disease patient care?
Yeah, absolutely, and thanks for having me. I would highlight two pieces. I think number one, the assistance for unemployment insurance, while not a direct healthcare policy, it has such a dramatic effect, especially on the work that we've done with regards to the sources of healthcare coverage that people have and whether or not that prevents shifts in from coverage to the uninsured. And we see that we've seen that play out throughout the year. And a large question going forward is whether or not those types of benefits will be continued and what effect that will have on the insurance coverage. I would say the other big category is payments to providers to make up for losses either due to increased costs or deferred care, where the COVID pandemic has really had a transformative impact on providers, and some of that assistance via congressional action has really been a lifesaver for many providers.
Do you think, Matt, that any of those policies will really stick into 2021?
Well, I think the big one up in the air is the unemployment insurance benefits and perhaps increased benefits beyond kind of the standard benefit. I think we see that debate going on right now. And we saw this repeatedly back in 2009, 2010, where Congress would frequently take a look at the economic activity or recession or unemployment numbers and have to make a decision about whether or not those continue. And I think that is something that Congress will think about for the remainder of this year and potentially into next year. And I think that the answer to that question will have a tremendous impact on the insurance landscape and sources of coverage for patients.
Right. So Kevin, talk us through the CMS, the Center for Medicare and Medicaid Services piece of this. So I want to start really high level and come down from there. And the first question really is, CMS, has played an outsized role this year in the COVID response. It pushed through a lot of changes throughout the healthcare system. Can you explain why patients and advocates should pay attention to what CMS does?
Sure, thanks, Ryan. You're correct that they really have been trying to provide a lot of flexibility, particularly in ways that provide the ability for physicians and hospitals to provide care to patients in different kinds of settings, whether it's telehealth or a relaxation of conditions of participation. So there are different kinds of facilities that can become emergency rooms or become hospitals. So I think they've really been trying to work with various stakeholders in the healthcare community to provide as much flexibility as possible so that patients continue to get access to care, even when normal systems don't work as well as they could have because of the COVID crisis.
So Kevin, a quick follow-up. Do you think, we've seen this sweeping activity. Does that change the dynamic for the future, you think, with CMS, or do you think that CMS kind of goes back to business as usual as, the pandemic hopefully subsides? Or, are there implications for all this activity for 2021 and beyond?
Yeah, I think that that's very similar to the way all of us are approaching what's happened because of COVID. You see things that you had never tried before that work better than you thought, So I think a lot of consulting is going to be done remotely. I think some healthcare has been done effectively via telehealth. So I think they're going to try to learn lessons from what worked in this process and then build on that. And so we've already seen them trying to expand telehealth permanently in some instances, and they're looking at different categories that they'll potentially continue in 2021. And I think that they'll start doing that in a variety of the different kinds of things that they've done. So some of the physician supervision changes and other things that may make it easier for patients to get care in different settings, they may look to the extent that they think that those flexibilities have worked, continue them along, even as they're trying to get back to business as usual, where that's most effective.
So let's look forward to 2021 a little more. And so Emily, I want to talk about legislatures, both federal and state. And I'm curious, Emily, what policymakers and staff on the Hill are talking about. Oftentimes, obviously we're in the middle of a presidential election, and you hear, each side kind of staking out what their priorities might be. But what I'm curious is, do you think legislators on the Hill have priorities of their own that aren't necessarily being broadcast on the campaign trail that we're going to hear about, after the election happens in November?
Such a great question. Thanks, Ryan, for having me. Of course, policymakers always have priorities of their own, regardless of the election year, regardless of what's going on in the world. If I were to pick sort of the top two or maybe three, for me, I see things falling into two buckets. And I think what's been interesting about the pandemic, such a transformational event, is that health advocacy is COVID advocacy and COVID advocacy is health advocacy. You can't separate the two now and for the foreseeable future. And so it goes for the policy landscape as well. So top of mind, certainly right this week, will they or won't they negotiate another COVID relief package? I think it's looking like they won't, at least not before the election. So I might expect early in the next year, possibly lame duck, but more likely January, February, a major stimulus package that will touch health policy, economic policy, and a lot of the issues my colleagues have been talking about. I would see that, in that regard, it feels a lot like 2009, where we had a recession during a presidential election year, and coming right out of the gate, the new Congress had the American Recovery and Reinvestment Act. So I could expect a replay of that. Healthcare, of course, always top of mind. It's been heightened by COVID. but I think the death of Ruth Bader Ginsburg and the forthcoming SCOTUS case with California v. Texas on whether or not the Affordable Care Act is constitutional is huge and really top of mind. That case will be held before the Supreme Court on November 10th, presumably with a new justice in place. And while you're going to hear a lot on the campaign trail, Democrats have already pivoted to the ACA will be overturned. You're going to lose your pre-existing conditions. Probably more likely, it will fall somewhere in between total repeal of the ACA and ACA totally standing. And so while they're not talking about it publicly, I would anticipate that lawmakers already top of mind are thinking about what can they do legislatively to shore up the Affordable Care Act and or strengthen the Affordable Care Act, given 10 years of lessons learned with the law on the books. There are lots of other priorities that are being talked about on the campaign trail that we're monitoring, the American Heart Association. I've been really interested to see on both sides of the aisle in several competitive races the issue of surprise medical billing and how much candidates are talking about that, tweeting about it, running ads about it. So we know that there's legislation bipartisan sitting on the table now. If we don't see that in the lame duck, we might see that early next year. And I think the other thing coming out of COVID policy that I think is a real positive for patients, as does the American Heart Association and other patient groups, are the loosened restrictions around telehealth and efforts to make that permanent as a result of the pandemic. So those are just some of my thoughts.
That's great. Thank you. So Frank, I want to bring it to you. You know, a lot of times it's easy to get caught up in what's going on in Washington, but we can't forget that there are 50 states and they have priorities as well, and their situations may be different. So I'm curious to hear from you. What do you think is at the top of mind for states when it comes to healthcare policy and ensuring patients have access to care?
Well, for our members and their efforts to increase access and quality care, I mean, their advocacy has to be patient-centered advocacy. They can't go to the state legislatures and just kind of frame their problems. It has to be all tied in to the long-term health of the patient, because as everyone said, there's not a bright line ending to COVID, and then we just go back to where we were. So the prior authorization is going to be a very big issue. It has been for some time, but it's going to be even more important now. The previous, Ms. McAllister, by the way, did a fabulous job of explaining how prior authorization restrictions don't, how they impede care, and it slows down the whole process. So it's not just, the particular patient, because there's so much paperwork to be done, so much administrative work. That's going to be probably the biggest issue that our members and patients together are going to have to work on. And it's been going on for a while, but the rules of the game are completely different now, because it has to be explained to lawmakers as to where a patient is with regard to COVID. And then when you have, surges, hopefully not, but, surges where there's an increase in cases and whatever unexpected things happen, those things are going to have to be dealt with, and we're going to have to educate lawmakers, but it can only be done with patients together and with other members of the care team. It can't just be physicians. It has to be, nurse practitioners, everybody working together. As far as telehealth, that's a lot of good things have come out of that. The governors acted very quickly to provide that benefit, and it's worked out very well. It's going to have to be looked at under a different lens as things change. But I think prior authorization is going to be a very important issue, and it's going to be state by state too, because in some states you're going to really have to work directly with the payers. They're willing to do so. We've had some really good results with that, and just coming to the table. Other states, it's going to be the insurance commissioner. Other states, you need really urgently, push for legislation. So a lot on the table there, but I think that's going to be really where the action is with a lot of the patient, physician, and patient provider issues.
Let's talk about advocacy in 2021. And Kevin, as we mentioned earlier, CMS has played an outsized role this year, I think, and from access to telemedicine services, which has been talked about, to how copay cards count toward a patient's deductible, for instance. I think a lot of people, see how much influence CMS has, and they think, how do we inform CMS about the patient experience? So my question to you is, how can patients and advocates best engage CMS and impact its conversation and process?
So yeah, Ryan, you're right, particularly with copay cards and accumulators, kind of for patients that are in high deductible plans, which have been an increasing part of the health policy landscape. The impact of copay accumulators is really a big deal. The agency has done some things lately that have allowed insurers a lot of discretion to use them. And I think in trying to deal with patient access issues, that's potentially a problem for patients and patient groups. I think in my experience, trying to convince CMS or another government agency that they're wrong about something or that they made the wrong decision isn't always as effective as trying to present to them the case that maybe circumstances have changed, and that as more people are losing their coverage because of because of COVID, or shifting into high deductible plans, that allowing assistance and copay cards to not count toward deductibles will be an important part of improving patient access. And so perhaps that's the kind of messaging that would be useful for patient groups and other advocates to use, and trying to convince CMS to maybe walk some of those things back a little bit.
Right. Okay, really interesting. So, Frank, I had a question for you about ACC members and what their priorities were, but I think you covered that with prior authorization. So actually, I'm going to skip to our next question. And Emily, I'm going to start with you, and then we'll go around the horn. So I'll start with Emily, and then I'm going to kick it to Matt, since we haven't heard from him in a bit. So, Emily, you're speaking to an audience of advocates and clinicians who care about health policy and access to medicine. So where would you encourage people to focus their effort in 21? Is the real opportunity with CMS? Is it at the state level, Congress, or pushing the executive to take action? 30 seconds, what would you encourage folks to focus on?
Well, unfortunately, I think it's all of the above. You can't choose one above the other. I mean, but for me, obviously, my last response is probably leading. Top of mind is it's SCOTUS. What's going to happen with the ACA, with COVID? 700,000 surviving patients so far. There are more that they now have chronic conditions. Is COVID a pre-existing condition? What happens with pre-existing conditions? And well, of course, there's not much you can do to influence the Supreme Court. I think there is going to be a requirement for some legislative fixes. And so that's where I'm turning my attention. And I would urge advocates to turn their attention as well.
Matt, what do you think? 30 seconds.
Well, I think it depends on the issue, and it depends on the outcome of the election. I think both of those, you need to identify where is the policy making happening. If we have, if your focus is on the coverage debate and we have an election that gives us a split government, there maybe not be a lot of action on the legislative side, and maybe your focus is CMS. Your focus is, say, for instance, on the drug pricing side. I think independent of the outcome of the election, we're going to see action both on the administrative side and the legislative side. And so you may want to, split your focus. So I really do think it is an issue-specific question, and a question that can only be definitively answered after the election.
Frank?
A dark horse issue, if you will, for us, I think is clinician wellness is really important. That's something we're working very hard on, and we're working in each state. It's dealt with differently. In Colorado, for instance, they have a state oversight, and just making sure there's transparency so physicians, providers can have can get mental health services, because it's the most stressful time, obviously, in healthcare, and so many years. Those are really tough issues to navigate just because of the way they're set up in government. So I just wanted to bring that into focus, because it's something like the AMA is working on very, very hard in the specialty organization as well, because we obviously need a very strong provider community to help us through this.
So Kevin, I'm actually going to try to bring in an audience question here and let you answer this, and you can take us out. We have seen expansions in telehealth utilization during the COVID-19 pandemic. So I'm curious, on a scale of 1 being not likely at all to 10 being, certainty, how likely do you think it is that we'll see these telehealth expansions made permanent or semi-permanent?
I think for some of them, it's a 10, and for some of them, it's a 1. So it really depends on which expansions CMS and other stakeholders decide work. So I think that there are pieces of them that people think have worked really well, and so that those will be likely to continue. And for others, it will have to wait and see, and how all this turns out. As the founder of my company likes to say, 4 days is a lifetime in this town. And a few weeks ago, we weren't talking about a Supreme Court nominee, and we weren't talking about a lot of different things. So who knows how many other shoes are going to drop that would have an impact on where telehealth and other health policy issues will go.
Absolutely. It just shows there's a ton of nuance to these issues and a lot of moving parts, but we'll keep up the fight. So Emily, Matt, Kevin, Frank, thanks so much for joining us for this really interesting panel. We really appreciate it. Thanks, guys.
Thank you.
Very timely topic, Ryan.
Absolutely.
And clearly, it's a lot to digest as we look towards an election in a few weeks. And really, there are so many moving pieces in the health policy world right now. It's never been a more important time to be an advocate. I know that I learned a lot from that panel, and I hope that it brought some clarity to you all during a year that has turned the health policy world, quite frankly, upside down. Our final panel for today will explore a complicated but increasingly important topic in the health policy world. There's so much innovation happening in the cardiovascular space. New therapies and procedures are coming to market with increasing speed. It's very exciting to witness. On the other hand, there is a constant struggle to define value for new therapies, and that struggle often impacts access to those therapies as well. We'll explore this debate in the next panel, but to start, let's play a video the Institute for Patient Access released last year that will help frame our discussion.
If you had symptoms of a serious condition or a chronic disease, who would you call? Your doctor or an economist? The answer seems obvious, but here's the thing. Sometimes economists can have more control than your doctor about whether you get the medicine that treats your condition, especially when we're talking about the Institute for Clinical and Economic Review, or ICER, a group of health economists in Boston. ICER and your doctor are very different. Your doctor is interested in you and what you're experiencing. She might take your vital signs, ask questions about your symptoms, and review your medical history. ICER isn't interested in you or your experience. ICER is taking a one-size-fits-all approach, looking at a generic population of patients across the country with your disease. Your doctor performs tests or diagnostics to get a complete picture of your health. ICER performs economic calculations using clinical trials data that are often incomplete, inconclusive, or not reflective of your experience. Your doctor asks questions about what you want from treatment. ICER is only interested in one question, and it has nothing to do with you. Is this medicine worth its cost to the healthcare system? What happens when ICER says no? Health plans, Medicaid systems, and pharmacy benefit managers can block access to that medicine, even if the medicine is worth it to you or if your doctor advises otherwise. If you're thinking, that doesn't seem fair, you're right. If you're thinking, I'm not a number, I'm a person, you're right again. And finally, if you're thinking that doctors, not economists, should be the ones deciding which medicine patients get, yes, you are absolutely right. So speak out and learn more about value, access, and ICER at instituteforpatientaccess.org.
Thanks, Jasmine. And right now, the Institute for Clinical and Economic Review is assessing therapies for heterozygous familial hypercholesterolemia, which is an inherited condition that leads to high cholesterol levels, as well as cholesterol-lowering medications to prevent ASCVD. So our goal for this session is to explore how the cardiovascular patient population isn't one size fits all, and understand the difference between data and real-world experience, and talk about the need for individual clinician input to groups like ICER. Let me introduce our panel. Today, I'm joined by Dr. Seth Baum, who's a preventive cardiologist practicing, teaching, and conducting clinical research in Boca Raton, Florida. He's also the past president of the American Society for Preventive Cardiology and has been an ardent advocate for transparency and fairness with regard to medication access. Sarah Van Geertruiden is Executive Director of the Partnership to Improve Patient Care, and Sarah started her career working in the Senate, handling health policy, and has been with PIPSI since 2011, focusing on advancing policies and value frameworks that are centered on achieving outcomes that matter to patients and people with disabilities. And finally, Siri Veith, who is Executive Director of Cystic Fibrosis Research, Inc., or CFRI. Siri first became involved with CFRI in 1995, shortly after her daughter's diagnosis with cystic fibrosis. As director, she oversees CFRI's research, education, support, and advocacy programs, and is passionate about access to therapies for the CF and rare disease communities. Welcome, everyone. Siri, I always like to start with a patient-centered story. Earlier this year, pre-COVID, which seems like a lifetime ago, ICER undertook a review on cystic fibrosis treatment. Talk to us about what happened.
Well, I have had the experience 2 times now with ICER in their reviews of CFTR modulating drugs for the treatment of CF. And for those of you who don't know, CF is a rare disease. Only around 31,000 people in the US have CF. And it remains a fatal disease. Last year, the median age of death was 30. I have a daughter who's 25. That number looms large. For most people think of CF as a lung disease. That's because most people die from respiratory failure. But because of the CFTR mutation, that defect, it also can cause pancreatitis, diabetes, liver disease, sinus disease, male infertility. It's a very complex disease. So yes, no one size fits all for any drug. So along comes a drug recently. It is transformative for many. For the 90% of people with CF who can take this drug, it can be life-changing. And this was greeted with great excitement by all the CF community and CF medical caregivers because of its impact. So people had less exacerbations, less hospitalizations, improvement in lung function. I've spoken to people who survived COVID-19 who have CF who swear it was because they were on this drug and were stronger because of it. My favorite story is a woman who literally was at the hospital after getting the call for new lungs. She was an end-stage lung disease when the lungs were deemed to be inviable. So she was crushed. Her doctors were fearful she would not survive till the next lungs, put her on Trikafta early. She went off oxygen. She did not need a transplant. In other words, a game-changing drug. So ICER rushed to review this drug. They were caught by surprise because the FDA approved it because it was so impactful in record time. I think it was actually the second fastest review process in FDA history. So after they then invited all the patient advocacy groups to participate in the process, and after spending hours and hours sharing our most personal traumas, and challenges of living with this disease, the report came out and it was deemed to be not worth the cost, even if it was a curative therapy for us. And the bottom line is our community, as with many other disease groups, will never fare well with an ICE review. Because CF is a rare disease, our drugs are much more likely to be expensive because our numbers are so small. And most importantly with this discussion is that ICER's use of the quality adjusted life year will always penalize people with disabilities, people with chronic disease. So in the end, we felt we had gone through this review in good faith. Many of us participated. And much of this was taking place through COVID, in fact, where our resources were were stretched very thin. In the end, we felt that our pain and suffering wasn't accounted for, that the economic impacts of our disease were not accounted for, and that in the end, the worst thing was we felt that we, by our participation, somehow were used to provide legitimacy to the results of that report. So it was not a wonderful experience.
And Siri, that's so hard to hear, especially since the FDA had such an urgency behind making sure that that therapy would be available. Now, shifting gears to Dr. Baum, how is the value conversation a bit different for cardiovascular conditions, which are not rare, but actually increasingly widespread?
That's a great question. Before I answer that, though, I just want to comment on Siri's discussion and how powerful and disturbing it is to hear that, because here we are having a conversation about value of a drug, which means the value of a human life or human suffering. And so we're placing an arbitrary dollar figure on, what is a stroke worth? What is a heart attack worth? What is your life worth? And I think we all have to keep this in mind, because we sometimes forget in these economic conversations, and we can't forget, because ultimately what we're doing here is we're rationing therapeutics. Whether we like to call it that or not, we are rationing therapeutics. So to answer your question, though, when we have evaluation of the ultra rare disease versus the common disease, I mean, these things are pretty much polar opposites. The ultra rare disease, and we can look at homozygous FH as an example, 1 in 200 to 1 in 350,000 patients, so 1,000 or so in the United States. Very, very rare. Sometimes we find a drug company will produce a therapeutic that can be helpful in that patient population, and it can cost a few $100,000 a year sometimes. These very high numbers to treat these patients, but they have tremendous efficacy. So the problem is for them, they don't pass the cost effectiveness hurdle, but their budget impact is really minimal because there's so few patients. Well, the opposite occurs with the common disorder like heart attack, stroke, cardiovascular death. It is very, very common. Cardiovascular disease kills more people than any other disorder in the United States. And so when we find a therapeutic for that, often it will pass the cost effectiveness threshold, but it will fail on budget impact because so many people are being affected. We have to remember, though, that with regard to cardiovascular disease, there are far more impacts than we often consider. Whether it's relating to family involvement or caretaker responsibilities, or jobs, happiness, suffering. So there are many things that need to be considered that aren't considered, and everything seems to be organized in a very tight box with a nice little bow around it. But in reality, patients are all different, the experiences are all different, and we need to personalize, as I think we'll hear more about. We need to personalize the experience and our calculations. So that's pretty much it, Lindsay, for now.
Thanks, Dr. Baum. So, you talk about sort of that hidden cost or impact. Let's delve a little bit into how ICER does what it does. So, Sarah, measuring value is complex. So if you think about everyday life, we're measuring our time in hours and half hours, we're measuring our activity level in steps or miles, but how are you able to truly measure something like the value of a medication for a patient that's fighting a chronic disease?
This is a very good question. I'm so glad that you're having this conversation today. It is complex and no measure is perfect. And I think that's why we need models that are really tailored to help a person understand how we're measuring value in the context of outcomes that that patient is trying to achieve with their care. For policymakers, we would caution that policies should not rely solely on a one-size-fits-all metric to drive their coverage and reimbursement decisions, and that as a result may restrict patient access to care. PIPSI's chairman, Tony Coelho, often says that no patient is average. So the metric that's used by ICER is called the Quality Adjusted Life Year, or the QALY, and it's a metric that we would argue should never be a reference for public programs. And it's important to remember there's a 30-year history with this metric in the United States. People with disabilities have long opposed the use of the QALY in public programs. And in fact, you may remember that in 1990, the Americans with Disabilities Act passed. And in 1992, just after its passage, HHS rejected a state waiver application from Oregon that would have relied on QALYs to determine its Medicaid covered services because of the implications for discrimination under the Americans with Disabilities Act. Then in 2010, Congress reiterated that position when they passed the Affordable Care Act and included a provision that would bar the use of the QALY in the Affordable Care Act in Medicare for use for coverage and reimbursement decisions. So there's a long history of this country recognizing that QALYs discriminate. Now, really, I think it's important too during this moment when we're dealing with COVID and everything else, because if you think about it, the reason that they banned this metric is because the QALY imposes a value for a life with a disability that is worth less than other lives. So that's the basis of that metric. And then it also relies on subjective perspectives of a person's quality of life, which are achieved by doing surveys of the general population that then measure the effectiveness of a treatment. So for many patients and people with disabilities, an incremental improvement in their quality of life may not seem like much to an economist, but it may mean for the patient that they can rely less on a caregiver or go to work, which for them is a huge benefit. And so the ultimate result of using these metrics and value assessment is discrimination.
And that's interesting because we know that some states like Oklahoma are actually taking steps to effectively ban the QALY. There's legislation that just passed there for some of the reasons that you just mentioned. So Dr. Baum, talk to us for a second about a real-world CV patient you might see in a clinic as opposed to the clinical trial patient data that ICER really relies upon to make these important decisions.
Well, interesting question. And actually, if you really look at the question you just asked, Lindsay, it frames the answer because you asked for a comparison of a real-world patient and the ICER patient from clinical research. There is no single real-world patient. That's the whole point, right? Every patient is unique. Every patient brings to the office, to our discussion, to our management, his or her own special issues, and there is an infinite number of differences that exist between one patient or another. I think the most dangerous aspect of this, though, with regard to ICER and how ICER does its calculus, is that in creating or in establishing the value of a drug, numerous calculations are made. Probably the most essential one that impacts the output, or how valuable a drug is what the event rates are. In other words, when you're looking at a given population, how many of them will go on to have a stroke or a heart attack or cardiovascular death or multiple cardiovascular interventions, stents, bypasses, etc.? So the question is, what is that event rate? Well, if you look at clinical trial data, and I do clinical trials, we know that the event rates in clinical trials are much, much lower, sometimes a third or even a quarter of what they are in real world populations that are the same patient population. They're just not in the trial. And I'm talking about in the placebo group. I'm not talking about in the drug arm, okay, in the intervention arm. So, many of us wonder why this is. It's probably because of the oversight in these clinical trials. There are multiple layers of clinical oversight. And so the placebo arm, the event rates are much lower. In real world, they're much, much higher. So what this means is the value of a drug based on ICER's calculation, which considers clinical trials, the value of the drug is much, much less because the event rates are much, much lower in the population that ICER's looking at. It's a really, it's a false assessment of drug value, and it's dangerous because it restricts, ultimately, as we'll see soon, it ultimately restricts access of very, very important drugs to our patients.
Well, and that's a great point. I want to shift it back to be patient-centered. Siri, an important part of this value conversation is what a particular treatment might mean to the actual patients who need it. So how does ICER incorporate patients' perspectives, do you think?
Well, on face value, they'll say that they are very committed to engaging and hearing from the patient voice. But I guess I would describe their review process as purposefully anti-intuitive. So they are asking patient groups to share these stories, but the measurements, as were mentioned from clinical trials. So for this drug, for us, it was lung function. But as we know, there are multiple complications of CF, and lung function as a measure of effectiveness of the drug was just one tiny little perspective. And in terms of the whole process, and this will apply for anybody who's undergoing a review, they're going to invite public comments. They're going to have a review team that very purposely does not include an expert in the disease group, that the drug will be treating, to somehow reduce bias. Everything is, you have to submit things. They tell you what font to use, what font size to use. It has to be Word, not PDF. I mean, it's just little details that make it very hard for just opening it up to public input. It becomes a project for people. Then they have a separate committee evaluate the report to vote on it. Again, no experts in that field. And it's very hard because we are trying to say, listen, here are the multitude of ways we are suffering. Here are the multitude of ways we actually are valuing these improvements. It may be improved lung function. It may be less time in the hospital. It may be, as Dr. Rom said, having joy, being able to pick up your child, which you did not have the strength to do before, being able to finish a degree, maybe pondering going back to work. There are all sorts of things. Parents who step out of the professional field to care for their kids, and I will say usually that is the women that are stepping out of their professional fields. So these things are not incorporated, both impact of the disease, impact of the drug, economic impact of the disease and of the drug upon treating this disease. And it sounds really petty, but these committees, I've presented twice. Once people had their backs turned to us in the room. This most recent one, literally one of the panel members was falling asleep, and there was a person with CF saying, I'm so sorry that my experience is not interesting enough to keep people awake. ICER will always say they don't like to have patients involved in any kind of voting capacity because we are just too emotional. And but the fact of the matter is, of course, we're emotional. We do want to survive. We want our loved ones to survive, but we also are experts in our disease, and we felt much more than the people sitting on the committee who were making decisions about a drug that will change our life. And again, I felt really that we were providing ultimately legitimacy when in the end it was the absolute opposite. We felt there are many hoops to jump through, which made it difficult for the public to participate. And in the end, after jumping through the hoops, they did not hear us or incorporate that.
Well, and that seems to be a continuing theme, because we know that approximately 92% of ICER reports are adverse. We're very long time, so I want to jump ahead and just two final questions, one to Sarah, one to Dr. Baum. First, Sarah, so ICER comes out with a report. Walk us through rather quickly, if you can, sort of the impact or the how insurers use that information, how coverage decisions might be made, and sort of that black box, as you've called it, that's pretty nebulous.
Yeah, it is interesting. When I mentioned before that the Affordable Care Act included a protection against the Secretary using QALYs in Medicare to determine coverage, but at the insurer level, and even for Medicare Advantage plans, the pharmacy and therapeutic committees, also known as P&T committees, they often use ICER reports, which are based on QALYs, to inform their coverage and step therapy decisions. But the problem is that we don't know the extent to which those reports are informing that decision or really driving that decision, although we can speculate based on the alignment between what the insurer decides to do with a newly approved product in terms of their benefit package, compared to what the recommendations were by ICER for payers. Now, there was one more transparent example in 2018 where CVS Caremark actually announced that they were going to create a benefit package that was going to be based on a cost per QALY benchmark, where anything that was below that would be covered and anything above that would not be covered. I would guess that the treatments that we're talking about being reviewed by ICER right now would probably have not met that criteria and would have not been covered in that benefit package. So, but there was a lot of pushback from the patient groups. CVS Caremark ended up stopping marketing that program, which was, I think, somewhat of a success. But we do know that still behind the scenes, in that black box, these studies are being used by insurers, just not transparently to the rest of us. I would also point out that the VA has a partnership with ICER. It is not clear the extent to which the VA, how that actually drives their formulary decisions. The VA would argue that it's only being used for negotiation purposes. But when asked, well, what happens if you don't get the price that you want? What happens to then the coverage on the formulary? They don't have any really great answers. And so if you look at ICER's decisions in terms of what is or is not cost effective, it more or less aligns with the VA's formulary. So we're pretty sure that ICER studies are driving a lot of decisions in the formulary at the VA as well. So I think it's just something we really have to look at. The provision in the Affordable Care Act is great, but we do think that we can and should go further with making sure that QALYs are not informing coverage decisions, both in Medicare and in Medicaid, because many states are now starting to look at QALYs to inform their Medicaid programs as well.
Well, and it certainly drives home the point that folks need to keep their eye on the ball on this. And so, Dr. Baum, to close out, can you talk a bit about what individual doctors, nurse practitioners, how can they add their voice to this ICER conversation? We know there's an open comment period that's coming up actually in November. And so talk a bit about that, and then we'll close our panel.
Sure. Well, first of all, it's essential that all clinicians, doctors, nurse practitioners, nurses, others, engage in this conversation. We need to do this because ICER has far too much power. They're self-appointed. They are having an impact. Boy, do I wish I had more time to talk about what they did to the PCSK9 inhibitors. Lindsay, maybe you'll allow me to do so after. But when it comes to what doctors, nurses, and other clinicians can do, well, first we need to make sure that we learn a bit about health economics. At the American Society for Preventive Cardiology, we created a Health Economics 101 course specifically designed to teach healthcare practitioners the basics of health economics, the basics of understanding the valuation of a drug, and what ICER and others do to value drugs. And I think it's very important that we all get to that kind of level playing field of understanding. But in addition, it's the obvious thing is we need to write to ICER. We need to weigh in on this. But in the November 11th to December 12th, somewhere around then, there's an open discussion period or a comment period rather. I would encourage all clinicians to write something and send it in to ICER. We need to deluge them with these comments so they understand that we care and that we know what they're doing, that we have our eye on them. So that's what I would say, Lindsay.
It is a lesson learned from, as you alluded to, the previous major ICER review in the cardiovascular space. I want to thank this panel for a great discussion. We're low on time, but this is such a timely topic, Jasmine, because we do have a webinar in 2 weeks about how, as Dr. Baum spoke about, clinicians can engage with ICER, and so folks will be getting more information about that next week.
Thank you.
Yes, Lindsay, that will happen on October 20th. So again, please look out for information about that. And following to what Dr. Baum said, we can all remember so clearly ICER's review of the PCSK9 inhibitors in 2016. Their assessment completely hindered patient access to a therapy considered life-saving to millions of people. And that negative impact that had on patients, it was tremendous. And so that's why it's critical for clinicians, patients, and advocates, as you all discussed, to have a prominent voice in health technology assessments.
Jasmine, that wraps today's summit. And I have to say, I really enjoy this event every year because we can all meet in Washington and talk about these important issues, we network, spark new alliances. But this virtual meeting has been fantastic. I want to thank Jasmine and Lindsay for co-hosting with me today. Thanks to all of our speakers, all of whom are extremely busy. They're experts in their field, but they're extremely knowledgeable about these topics, and they really inform all of these debates. And thanks to all of you who joined virtually. I want to say the Partnership to Advance Cardiovascular Health is a coalition of organizations that care about health policy and cardiovascular disease. If you represent an organization that is aligned with our mission, please consider joining by shooting us a note. Membership is free, and we believe more members and perspectives only makes us stronger. Finally, as we mentioned, there are some upcoming programs you can join. The ICER webinar, as Jasmine and Lindsay mentioned, is on October the 20th. We will also host a virtual town hall focusing on unmet needs for heart failure patients on Friday, November 13th, during the American Heart Association scientific sessions. You can find more information about both programs on our website at advancedcardiohealth.org. Thanks, everyone. Be well. Stay safe.